Hello, everyone. This is Chadi Alraies coming to you from Hard Trending. This is our monthly series every Thursday at 6 p.m. Eastern Time. This series coming to you with one CME credit. Thanks for FACET for organizing this and putting it together, and also for the CME credit. I'm really privileged today with a colleague and friend who have been a really pioneer in the interventional field, especially in complex coronary intervention, Dr. Azzalini. He's the Director of Interventional Cardiology Research and Associate Professor of Medicine at the University of Washington in Seattle, Washington. He graduated magna cum laude from University in Padua in Italy in 2006. He subsequently completed his cardiovascular training and master's degree in research methodology and PhD in medicine at Autonomous University of Barcelona in Spain. He completed two fellowships in interventional cardiology at the Montreal Heart Institute and Mount Sinai Hospital in New York. Before joining University of Washington, he was director of complex coronary intervention at Virginia Commonwealth University in Richmond, Virginia. His clinical and research expertise is represented by chronic total occlusion or CTO PCI, plaque modification, mechanical circulatory support, and acute kidney injury after PCI, and the vascular access. He has published more than 320 peer-reviewed manuscripts, including several publications in the Journal of American College of Cardiology, Circulation, European Heart Journal. He received numerous interventional awards and and is member of the editorial board of the Canadian Journal of Cardiology, Interventional Journal, International Journal of Cardiology, Cardiovascular Research of Medicine, and Cardiovascular Revascularization Medicine. Interesting cases, International Cardiology Reviews, and Research and Resources, and Minerva Cardiology and Angiology, and is guest editor for other 20 journals. His free time, Dr. Azzalini enjoy spending time with his family, traveling, cooking, and sailing. Please welcome with me, Dr. Azzalini, for his presentation. And today we ask him to talk about a very specific topic, which is complex coronary intervention, or what do you do? Like, how do you do high-risk intervention in especially managing SVG versus somebody who has a CTO with chronic angina? With that, Dr. Azzalini, I'll give you the mic now, and thank you so much for your time. We'll have a question throughout, so use the QA box during the presentation, but also we'll talk also again.
Thank you so much, Chadi, for the introduction, and very glad and honored to be here to share with you some discussion about this currently hot topic, basically. Should I treat the diseased SVG or the native CTO? I hope you can see my slides, and also you can put the question in the QA, and also, Chadi, if you have any hot question, you can stop me anytime during my presentation. So these are my disclosures. Okay, so what are we talking about? We're talking about SVG intervention. SVG is a very tough and challenging lesion subset because it's associated with a higher rate of complication. This is one important study is published on the topic called the DIVA trial, led by Manos Brilakis, that basically randomized patients with SVG disease to either DES or versus bare metal stent intervention. And as you can see here, there's a very high rate of adverse events during the follow-up. We have double-digit figures of target vessel MI for both DS and BMS, and a very high stent thrombosis rate, 3% in both groups. And so SVG PCI is associated with very high rate of target vessel failure, MI, stent thrombosis, and TDR at just 1 year follow-up. And this is importantly the only lesion subset where DS did not outperform BMS, unlike any other known lesion subset other than this one. So it's important to know that the SVG failure is usually not a trivial phenomenon. Most commonly, this patient present with ACS due to acute graft occlusion. So very symptomatic, very high burden of acute disease with adverse outcomes in the immediate post-procedural period. So how many PCIs are performed in patients with prior CABG? So these are a couple of important registry. The NCDR on the one end, and on the other hand, we have the VA cart. Both studies, again, led by Dr. Bilakis. So approximately 1/5 of patients undergoing PCI in the United States have prior CABG. So in prior CABG patient, PCI target was the native in 3/4 of the case and the graft in 1/4. So these patients that undergo bypass graft PCI have higher risk characteristic, higher burden of comorbidities, and also higher rate of procedural complication with more requirement for intra-aortic balloon pump. They have more pre-procedural MI, more no reflow. They have lower incidence of final TIMI flow and higher in-hospital mortality. Importantly, these higher rate of complication also translates in higher risk for adverse events, including death on long-term follow-up. And these are adjusted analysis. You can see higher risk of death, MI, and TVR on follow-up, on a median follow-up of 3 years. So patients with CABG are high risk and complex. They're usually older and frail. They have higher prevalence of cardiovascular risk factor and comorbidities, particularly CKD and diabetes. And they have a complex atherosclerotic lesion morphology. In particular, the graft, particularly the SVG, have a friable and very atheromatous plaques. And on the other hand, if we are planning on intervening on the native, we have accelerated native coronary atherosclerotic disease progression after CABG. And so we have very long lesion with a severe calcification, and there is a very, very high rate of chronic total occlusion, between 50 and 90% in most series. Based on observational studies, and this is a meta-analysis of the literature available until a few years ago. So native vessel PCI is associated with improved outcomes compared to bypass graft PCI, and most studies clearly signal these. There's lower MACE, all-cause death, MI, and TVR compared with bypass graft PCI. As a consequence, based on that, guidelines until recently, at least both the US guidelines and the European guidelines recommended to perform PCI whenever feasible on the native coronary artery over PCI of the severely diseased SVG. And these, as you can see here, it's even marking in the US guidelines, is based on non-randomized evidence, basically most of the studies that I showed in the previous slide. So the big news, the big elephant in the room that was published and presented TCT recently is the Proctor trial. So the rationale of the Proctor trial is to randomize patients with CABG to either native vessel PCI or a bypass graft PCI, because there is no trial before Proctor on this topic. And so this is the first randomized study on this topic. So inclusion criteria, so you needed to have at least 50% stenosis on the SVG. There should have been a clinical indication for percutaneous revascularization as determined by the heart team. And then importantly, both the native artery PCI and the SVG PCI had to be deemed feasible under a technical point of view for PCI by the heart team. Importantly, key exclusion criteria, and we will come back to these later. So early CABG failures, so CABG performed less than 1 year prior to inclusion, presentation with STEMI, or high risk and STEMI with ongoing ischemia, for example, with hemodynamic or electrical instability, persistent EKG changes, refractory angina, and heart failure. Vessels could not be smaller than 2.5 or larger than 5.5 millimeter, and patients with aneurysm or a very high thrombus burden in the graft were also excluded. So they screened 341 patients, including 220, 108 randomized to PCI of the native artery, and 112 randomized to PCI of the SVG. Primary endpoint at 1 year was a composite of MACE of all-cause death, no fatal target vessel MI, and clinically driven target territory revascularization. They did a good job and not losing a single patient on follow-up. And there were some minor crossover, particularly in the native vessel arm, probably because there were several CTOs, as we will see. Characteristic of the baseline population, it's a slightly older and more comorbid patient population. compared to the majority of other coronary trials, age about 73 years on average. Vast majority were men. Almost half of the patients, 43 and 47%, had diabetes. Importantly, 1/3 had CKD as defined as eGFR less than 60, and very high burden also of cardiovascular disease, with 2/3 almost of patients that had PCI before, and more or less a half that had prior MI. Importantly, most patients had a very remote history of CABG, approximately 17 or 18 years prior. Target native vessel coronary arteries affected in half of the patient, the RCA. Importantly, and this is important to consider also the success rate, native vessel PCI had 83% of the CTOs. So this is basically a trial of CTO PCI in natives versus PCI of the SVG. Another important factor, only 8% of patients in the SVG group had actually in-stent restenosis. So these were mostly, in the vast majority of cases, these were a de novo SVG lesion. Technical success was good and high, 92, 93%, with no differences between groups, but there was much higher average number of stents implanted in the native vessel PCI, because the total lesion and hence the total stent length was almost 4 times as high in the native vessel PCI arm, 84, versus the SVG arm that only had 23 millimeters on average. So in most cases, it was just one single stent in the SVG, and in the native artery, it was close to 3, basically. And of course, procedural metrics reflected higher complexity of the basically the CTO PCI in the native vessel PCI group. Primary endpoint at 1 year, MACE was almost twice as high, 34.3% MACE in native vessel PCI versus 18.7% in SVG PCI. And this was a highly significant hazard ratio of 2.1 with a p-value of 0.004. Mortality, however, was not different between group, 5.6 and 3.6%. This is, in most trials, you don't have such a high mortality in neither, in none of the group, basically. But in these trials, since we're talking about very comorbid patients, 4 to 6% of patients almost had 1 year mortality. With regards to target coronary territory MI, there was twice as high of a risk of target vessel MI in the native vessel PCI, and most events were pre-procedural MI. As you can see here, 30% in native vessel PCI and 1% in SVG PCI. Of course, this is like mandated by the trial. It's not something that we routinely collect the biomarkers after a PCI, either in native or in SVGs, and we will have to see how many were actually clinical evident. I think the definition they used here was the SKY definition of 10x the value of CK&B. For target coronary territory revascularization, again, native vessel PCIs had higher incidence of event, 18.4% versus 9.1% in SVG PCI, with a hazard ratio of 2.2 and log rank P of 0.039. So they concluded that basically, whenever we face this problem, we should go for SVG PCI, because this is associated with lower MACE, target vessel MI, and target coronary territory revascularization. But there are many caveats and issues and limitations of this study. So the study included only less than half of the planned in sample size because of early termination due to the due to an interim analysis showing the superiority of SVG PCI. This is a very selected patient population. As mentioned before, only 8% of patients had ISR in the SVG group. STEMI and actively high-risk STEMIs with the ongoing ischemia were excluded. Early graft failure, SVG failure before 1 year, were also excluded, and these are also pretty common events that we treat in the cath lab, unfortunately. They excluded grafts that were entirely occluded, and also they excluded aneurysmal and heavily thrombotic grafts, which also represent a large proportion of our ACS population in SVG patients. Very, very important. Only 16% of patients had intravascular imaging guidance in the native arm, 23% in SVG arm, 9%. And when you are stenting 84 millimeters of length, intravascular imaging in 2026, or even a few years ago, in my view, is mandatory. There's a high likelihood that if you stent 84 millimeters on average, you're going to have some underexpansion. You might have plaque burden at the edges, dissections, and you really need to do a good job. And it's very many times when I do a CTO PCI, I find something after stenting and post dilating, even a high pressure, I still find some underexpansion, maybe some excessive plaque burden at the edges. So I use and or OCT in 100% of my cases, and I can tell you that in CTO PCI, I tend to go back in after the so-called final IVUS run and do some further optimization. And again, the primary endpoint was driven by in-hospital MACE events, mainly peri-procedural MI, the significance of which has not been demonstrated, is not as strong as a spontaneous MI during follow-up. So who do and who don't Proctor's results apply to? So the typical poster child of Proctor is a patient with stable angina or low risk non-ST elevation ACS due to a simple, short, non-thrombotic lesion of the SVG. What if we if we have a patient with occluded graft? These were excluded. Early SVG failure, excluded. Graft with a lot of thrombus, also excluded. Patients with multiple stents that keep failing in the SVG, these were excluded too. So these are important considerations when we frame the discussion about this topic. So a typical example of a Proctor trial case would be this. Patient with a left main CTO, flash ostial left main, very long, extending into the circumflex and LAD, with very limited retrograde options and a very, very focal and easy to treat and to stent with direct stenting SVG lesion. You can stent it, and then you gotta get a good result. This is the first episode of SVG failure in this patient, and he will be better served with PCI of the SVG. However, Proctor excluded these cases with a thrombotically occluded SVG, with long stents here and here, repeated recurring ISR, very significant and high thrombotic burden. These are not cases that were studied in Proctor. So if you try to open this up, you will have most likely no reflow. And the patency, the likelihood of the durability of this procedure will be very, very limited. So let's have a look at some of my cases here. So
Lorenzo, that's a very good point, because I think from your experience, how many cases do we get for NSTEMI compared to stable ischemic disease with occluded graft? I mean, from my experience, at least personally, they come with NSTEMI most of the time.
Absolutely. That's exactly my experience. Even so, the majority of the times when we have inpatients, they come, with NSTEMI, many times with thrombotic SVGs that would not even qualify for this trial. But even if we see when we see patients in clinic for elective CTO PCI, they've had a prior or multiple prior episodes of SVG failures that were treated at an outside hospital that referred the patient to us later with primary PCI or anyway urgent PCI on the SVG. So I'm not saying that these patients do not exist, but within the realm of SVG PCI, that is a highly comorbid group of patients, they probably selected somehow patients with lower comorbidities and better presentation. So I still think that whenever you find and we can talk more about that later, whenever you find a patient that fulfills all the Proctor inclusion and none of the exclusion criteria, you should go for a native artery for SVG PCI. Whereas in other cases, like the ones that are being displayed here on the slide, you should give consideration to native artery PCI. And this is a case that I had, like, I think 1.5 years ago, 70-year-old man with a cabbage approximately 20 years prior, SVG to LAD, OM, and RCA, presented with anterior STEMI, LVF 28%, and high LVDP of 25. So in this case, what should we treat? He has a SVG thrombotic lesion, SVG to the LAD graft, the LAD CTO. What are the risks treating either? And so we know that CTO PCI for sure is fraught with a higher rate of complication, particularly perforation. So, when we have a perforation, 10 to 20% of patients will suffer tamponade, and the death rate is very high, 5 to 10%. So it's not a decision we should just take like lightly to go for CTO PCI. We need to see if there is a strong indication, or when there is, we have to be prepared for this. On the other hand, bypass graft PCIs that we just saw, was an independent predictor, no reflow, pre-procedural MI, in-hospital heart failure, and in-hospital and long-term death. So that's also a problem in these cases. So these STEMI patient would not have fulfilled the Proctor inclusion criteria. So there's this intriguing concept that I want to share about the stage revascularization of patients that present with ACS that have a saphenous vein graft failure and a CT of the native. Of course, it's not reasonable to think that at 3 a.m., any operator that is taking STEMI calls can embark, or should even embark, of course, in a complex CTO PCI, or even rotational atherectomy or IVL facilitated PCI of a native. So let's go back to our patient that has a very high grade stenosis and thrombus burden there in the mid SVG graft to the LAD. So we went in with IVUS. There was some friable plaque. We were prepared for the typical complication of no reflow. We do direct stenting. Still, the patient has no reflow, and you see it ended up with this gadget here. He had a need for impella because he became hypotensive and bradycardic and had to be resuscitated a little bit. So we were prepared for that, and we put the impella, and we got a decent final result. 1 month later, he comes back for stage LAD CTO PCI. LVF went up to 45% from 25%. You can see it, of course, the vein is still patent because it was just merely 4 or 5 weeks later. So you see the techniques. There was impenetrable proximal cap. We had to do base. There was significant calcification, so no regular balloon would allow us to go subintimal. And so we use IVL to facilitate base to crack the calcium, went to go subintimal. Then we went retrograde. We did reverse card. With some CTO technique, we were able to get a good final result. But as you can see, there's a competitive flow here distally from the SVG, because this SVG was probably like 5.0 and has still torrential flow. So at this point, and we're going to talk a little more about this, about what should we do with this graft. So we elected to perform a graft embolization. So we try with one coil. So with one
it's
plug.
so big. I don't think the coil will work, right? It's so big.
Exactly. So this is one thing. Usually, traditionally, we have been using coils to embolize graft, but the graft is huge. It's not like coiling an epicardial or septal small vessel. It's huge. They don't thrombose immediately. They might thrombose over the course of hours and days. So in some cases, like this one, we put a plug, but still the plug did not work immediately. So we stuffed the plug with also one coil, and that actually improved our result. And there was basically TME1 flow in the graft, and this will just occlude. And then we have a very good final result with still some degree of competitive flow, but the patient afterwards did fine. And of course, we check with IVUS our result, as I mentioned before. So stage graft and then native revascularization. So you have an acute SVG failure, stage 1, whenever, wherever, in the middle of the night, every operator should be doing SVG PCI. And then stage 2, after discussion with the patient and with the specialized operators, you can entertain the possibility of doing native coronary PCI, in this case a CTO. The last part of my talk and we can, of course, discuss a lot about this. What should we do with the graft? Should we sacrifice it or not? So this is a study from, I think, mainly Belgium and the Netherlands, led by Poletti and others. They basically compare the outcomes of CTO-PCI in patients with graft versus non-graft. Basically, patients with grafted CTO had higher lesion complexity and lower success rate, 70 versus 80%, than patients with no bypass graft to the CTO. Importantly, as you can see here in the Kaplan-Meier curves, persistent post-PCI graft patency was a strong independent predictor of CTO failure at 1 year. That underlines the need to occlude the graft. So, in North America, many operators, the rationale is that we coiled or embolized anyway the graft by default. So we don't have this data because we've seen and actually have had cases where, we coiled the graft and unfortunately, there was still flow in the graft, and then the native restenosis. I had 1 or 2 of these cases. So we routinely occlude the graft when there is a TIMI 3 or even 2 flow. But in many parts of the world, including in this case the Netherlands and Belgium, they could actually study analyze this research question because many operators do not usually occlude the graft, and this is the result basically. So what are the outcomes of embolization or sacrifice of the graft? So there are a couple of small series, one from the UK and one from a Progress CTO, 3351 patients. In one series, they used, in the majority of cases, plugs. In the other one, they used, in the majority of cases, coils. They were successful in most cases, and there was very, very low rate of TLF in both studies. So this should be reassuring that at midterm follow-up, 1 year or 2 years approximately, your native vessel will stay open. And this is very, very recent data presented at CTO Plus by the Progress CTO group. Again, this analysis of retrograde approach via SVG. So in Progress CTO, there's a few questions that in this case report format, basically they ask you, was the SVG patent for cases that use the SVG? So 3/4 of cases had a patent SVG. It's much easier to go retro in an SVG that is patent compared if it's occluded. But it's also possible to go retro if it's occluded. At the end of the procedure, was there residual flow in the SVG supplying the target vessel? Again, in the majority of cases, 2/3, there was a residual flow. But then, having seen what I just showed you with the, what happens if you leave it open, only 21% of graft were actually coiled or otherwise embolized. And so there is this disconnection between, the data and what actually operators do. And maybe it's a fear of killing something that was crafted by the surgeon for the, it's open. Maybe they say, oh, if the native fails on its own, the graft is still there, but maybe it's actually the graft that is causing the failure of the native being patent. And so this is the disconnect. And so I'm just going to show you 2 more cases of these just to make a point. So this is a 70-year-old man with failing SVG to OM1 and SVG to D1. He has a LAD D1 CTO and a circumflex CTO. Mm-hmm. So we opened the native circumflex into the OM with facilitated ADR, which is under dissection and re-entry. So since we dissected and then re-entered at the distal anastomosis, you can see here that there is no flow, basically TIMI 0-1 flow in the graft, whereas there is torrential TIMI 3 flow in the native. So this is a typical case where you can leave the SVG as is. You don't want to even spend your money on coils or plugs because the vessel is basically dying anyway. This very same patient 6 weeks later comes back for LAD D1 CTO PCI. And this again is a very complex recanalization, this time with a retrograde approach. We open it, but then you can see there is competitive flow from the SVG graft. And so what we did in this case, there was TIMI 3 flow in the graft. We do a coil embolization of the SVG, and then we achieve very good antegrade flow. So different treatment for different, not even patients, even this is the same patient, but different graft behave differently depending on how you recanalize it. And so the case, yeah.
Lorenzo, in this case specifically, so what is the cutoff for Timmy flow to say, I'm comfortable, I'm going to leave it alone, I'm not going to coil it? Is it one or two and above or and below?
Yeah, so the study that I showed just used TIMI 3 flow as a cutoff.
Three.
I would
Okay.
say that TIMI 0 and 1 flow, they're basically already dead, so no worries with that. I would say that TIMI 2 flow already, I would be concerned for a competitive flow and a restenosis. So I would say I would put a cutoff between TIMI 1 and 2. So TIMI 0 and 1, I just let it die on its own. And TIMI 2 and 3, I perform coil or plug embolization. And you can learn coil plug embolization from your structural or congenital heart disease colleagues. Coil embolization, I think, should be a skill set that everybody should know and master, because you can have distal wire perforation in a regular PCI, and you should be able to have coils in your cath lab to be able to solve it. And then finally, my take-home message is basically that 1/5 of PCIs nowadays are performing CABG patients. Patients who undergo bypass graft PCI are higher risk. They have higher burden of comorbidities, and as such, also due to the higher thrombotic burden and fibril plaque of the SVG, suffer high risk of short and long-term major adverse event, death, and TBR. In the light of the Proctor trial results, stable patient with simple short SVG disease should appropriately receive SVG PCI. Like in the case that I showed you before, very easy fix to the SVG with IVUS-guided direct stenting, and do not embark in very complex and potentially risky CTO PCIs, like the left main, long occlusion, etc. In case of SVG occlusion, earlier recurrent SVG failure, heavy thrombus burden, we should treat the native coronary. In 80-something% of cases, native coronary, as shown in Proctor, even in this selected patient population, it is a CTO. So if the native artery lesion is a CTO and no CTO PCI expertise is available at your center, you should consider referral to some dedicated experienced operator. And then finally, we should consider performing coil or plug embolization and sacrifice of the graft after successful native coronary PCI in case of competitive flow with TIMI 2 or 3 flow. And this is all I have. And yeah, please ask me any questions, and let's start a discussion here.
That's great. Thank you so much, wonderful family. Thank you, Lorenzo, for a great and insightful presentation. So a few things in terms of the ejection fraction. Would that determine a threshold? We treated the same thing. Even if you have a lima, would that determine if you need a patient that require intervention of the native or the SVG?
Yeah, so importantly, Proctor is a trial of SVG PCI, so the results do not apply necessarily to arterial graft and limas or rimas in particular. Usually limas have a very, very high patency rate of 95% at like 20 years. So when they fail, in my experience, they fail very early, so like peri-operatively. So in that case, again, they would not qualify, because apart from not being an SVG, also because this would be early graft failure. So this is a different story. It's not a graft that has been open for a long time, has a focal lesion, then you fix it. Many times it's a completely atretic lima vessel, and then you cannot just treat it like that because it's occluded. And again, occlusion of the graft is another exclusion criterion of the of Proctor. In terms of LVF, I don't think they made any caveats or inclusion and exclusion criteria based on that. I would say that if the ejection fraction is low, like any CTO patient that undergoes PCI, independently from the presence of or not of graft, if you're gonna go retrograde in a patient with an LVF that is very low through a dominant graft, that still is perfusing, you might run into trouble with ischemia and issues like that. But I think that it's a trial that applies exclusively to known early SVG failure.
Great. Another question came is related to sizing. Do you have, if you say if you intervene on the SVG, sizing of the stent, do you have any challenges or any tips for the size, especially with big SVG, and what size of stent do you use?
On the SVG?
Mhm.
Yeah. So well, my all my strategies like IVUS based. I tend to see that that these arteries are very sorry, these veins are very big and tend to use a lot of big stents. I would also
Mhm.
say that particularly if you think you're gonna it's a recurrent SVG failure and the patient presents in the middle of the night with yet another episode of ACS, you need to do something. Of course, you should treat the SVG first and then stage the native. But if you need to put a stent to jail some thrombus and prevent embolization, I would say you don't need to do as a meticulous job with the pulse dilatation as with native arteries because you can squeeze the thrombus through the stent strut and embolize.
Mhm.
There's a higher rate of no reflow there, and also consider that if you implant a 5-0 stent in a 5.5 or 6-0 vessel, even if you don't do anything, both the native or the SVG, if you plant a big stent in a big artery, the rate of restenosis is lower. Of course, the footprint of the stent is much higher in a small vessel. So also considering that you're going to come back and you re-intervene on the native pretty soon, the risk of restenosis there is quite low. And if you pulse dilate too much, and I've seen those cases, you can have perforation of the graft, and that's no fun at all. I can guarantee that.
Yeah. So to summarize the approach for ACS, especially somebody coming with a culprit with SVG in the middle of the night, go ahead and fix the SVG balloon angioplasty and fix it and restore T3 flow. If it is more kind of a chronic and more thrombotic and hard to do, stop and stage the native. Is that correct?
Yeah, exactly. So regardless, middle of the night, middle of the day, ACS with thrombus, you want to stabilize the patient. So you should go for SVG PCI. Then you can sit down, relook at the case, see if this fits or not the Proctor trial inclusion exclusion criteria, and then decide whether or not it's worth going after the native. Sometimes also these patients, even if there is an indication because there is a recurrent ISR of the native, of the SVG, there would be maybe an indication to go after the native. There are other considerations. Let's see if the patient, is up to that. Maybe many times these patients have very severe comorbidities like neurologic disease, degenerative disease. So, you treated the culprit in the SVG because you had to, because it was a life-threatening emergency in the middle of the night, but they might have also issues with quality of life. And so
Mhm.
even if there would be an indication anatomically to go after the native, maybe you don't do it. It's always a tailor approach. But in general, recurrent SVG failure, heavy thrombus burden, early graft failure, I would go for the native as a stage procedure. And we always have a discussion in the clinic of the pros and cons of these more complex procedure, particularly if we're talking about CTO PCI that has a slightly higher risk profile than native artery, non-CTO PCI native arteries.
Great. If there's a comment. I mean, I'm not sure. It's a quick comment. If you can help us with the indication for filter. This is a filter for protection in SVG. Do you have any kind of general rule when to use a filter for desembolization protection?
Yeah. So there is been some controversy. At some point they were strongly indicated, but then other studies more recently questioned their use. I would say that we honestly we don't see many of these patients with the SVG acute SVG failure here because a lot of our other hospitals in the network take care of those. But if the lesion, first of all, you need to have an anatomic compatibility to use a filter because you need a landing zone. I think it's about 40 millimeters distal to the lesion. So if you have a perianastomotic lesion distally, you cannot use it. I will still use it whenever it's feasible, if it's proximal or mid graft, because there's been also many reports that show their value. Also, not to lose our skills. It is important as we train fellows that they're going to go to an environment maybe when they're going to treat a lot of ACS patients. So it's important that they get trained on how to use distal body protection devices. The other caveat that I want to make is that for everybody out there, whatever happens, 99.9% of cases, you should not place a stent at the distal anastomosis, because if you do, then you will create like a very preferential channel from the graft into the native. And then if we need to later go in and open the native, it's going to be very, very hard. If you go from antegrade or re-enter through the stent strut, it can be done. We've done it multiple times, but it's much harder than if there is no stent. And if you want to go retrograde from the graft all the way into the native, it's much harder because you need to go to through the stent strut backwards, and the angle is in many cases already the angle is unfavorable. If you also add a stent, it is really going to make our life much harder. In many cases, it negates the feasibility of the retrograde approach. So in this peri-anastomotic lesion distally, in the distal graft, do your balloon dilatation. If there's still some thrombus burden, but there's TIMI3 flow, put them on 2B3A inhibitors, talk with your colleagues, and then maybe during the same hospital stay, to avoid that the lesion gets unstable again, you can go for native artery PCI if there is an indication. But we receive a lot of those patients from other hospitals. They get referred with standard distal anastomosis is so much harder, and you're going your patient and the next operator a disservice doing so.
That's great. I think we covered all the questions. I mean, it was a short presentation, but very, very, very impactful. Lorenzo, really appreciate your time. This is a very narrow field and very narrow kind of patient that we treat every time. But as we know, the CABG rate is coming down, and also the failure, the surgeon are doing a good job. But also, as you said, if you are a big tertiary care center, it's very hard to capture these patients because they come back closer to home. But again, great presentation. I really appreciate the work, and I appreciate the audience for being with us here today and for great questions that were brought to us. Again, for Dr. Azzalini, he's going to be at Sky. So anybody going to Sky, you have an opportunity to meet with him as well to continue the discussion. But again, Dr. Azzalini, again, thank you for coming to us from University of Washington, talking about CTO intervention for patient presenting with SVG failure, native versus HVG. Thank you so much for your time, Dr. Azzalini.
Thank you, Chadi, and everybody. Thanks for giving me this opportunity, and looking forward to continue the discussion at Sky, perhaps. Bye.
And for our audience, don't forget, this is a 1-hour CME. You're going to get a link for the CME collection from the FACET. Thanks for FACET family for organizing this. And stay tuned for the third Thursday of the month for the next Heart Trending webinar. Thank you, everybody, and have a good night.
Thank you. Bye. Good night.
Bye-bye.